Thank you very much. And it's an honor to be with you guys today. This idea of system complexity and the challenge of too much medicine is the theme of my work in general. But I thought that today, particularly given that the next talk is on the star ratings, the CMS star ratings, that we could use childbirth and variation in C-section rates as a way of thinking about how we can actually help patients navigate the healthcare system better. And so I'll say a little bit more about the theme just for context, and then maybe we can dive into this idea of how we help patients with all this complexity around us. But essentially, the idea is that in pretty much every other facet of our lives, scientific capability has made it simpler to do things. Like, anybody who sent an email today knows that science has made it easier for us to communicate. Although science has vastly extended our capabilities in medicine, it seems very much, both for clinicians and for end users of the system, that it's also made our lives much more complicated. And I've come to a worldview where I believe a lot of the harm that we're doing in medicine might be a consequence of this complexity. When things are more complicated, there's just more opportunities to mess up. And I think that there could be ways that we could intentionally, strategically simplify healthcare in data-driven ways. And so that's sort of my pitch. This is a graph that tries to tell the entire story of the last half century of healthcare. But basically, there's capability on the y-axis, there's time on the x-axis, and it shows that over time we're directionally correct. The left-hand side is 1955. Dwight Eisenhower is the president of the United States, and he has a heart attack. And while he's in office, and the White House physician recommends the state-of-the-art treatment, which was basically to sleep it off. He prescribed a month of bed rest. If you were to fast forward to 2017, the President of the United States, or really anybody who walks into an emergency room with a heart attack, would have gotten a beta blocker and a drug-eluting stent and an angiogram, basically $20,000, $30,000 of technology, but they would have lived a decade longer. What that tells me is that we, on average, are getting things right over time. The problem, if you're a patient or a clinician, is that when people get harmed in our healthcare system, they don't get hurt on average. They usually get harmed on the margin. And there are two margins that we should care about, the one where we do too little and when we do too much. I would argue that most of the systems we've developed to make patients better off, to make them safer, have been dealing with the problem of too little. If you think about it, checklists are about trying to get you to systematically do more things that you're not currently doing. What we lack at the delivery system level, or even at the patient level, are systems to prevent harms from too much. Of course, patients get hurt in both ways, so we need to be thoughtful about that. There are a lot of examples of the problem of too much all throughout the delivery system, but this is a pretty stark one. So it turns out C-sections are the most common major surgery performed on Americans and human beings and people in any group that you could construct, including the participants on this webinar and the viewers on YouTube. C-sections are overwhelmingly the most common major surgery performed. It didn't always used to be like that. We've arrived at a moment where about half the C-sections that we do are probably medically unnecessary, and the consequences of doing C-sections that people don't need are really tremendous. We're talking about $5 billion or so in spending annually in the United States. A C-section commands about a 50% margin per case, so whether you're a purchaser or a payer or somebody on the individual market, it directly affects the affordability of care. And when you do surgery, you see surgical complications. So we're talking about hundreds of thousands of women every year who are suffering needlessly from the fact that we picked up a knife and made a large wound on their abdomen. Trick with this, as a clinician though, is in the moment when you do a C-section, it feels like you're always right. Like personally, when I do a C-section, I know I'm always right, because if the baby comes out pink, I think it's a good thing I did a C-section, and if the baby comes out blue and looking kind of lackluster, I think it's a good thing I did a C-section. So either way, it's pretty good to be me. And that optics problem is a big part of the challenge here. This is a map of the world, and it shows countries in red where we probably do too many C-sections and countries in purple where we probably do too few. But for most of the landmass on Earth, C-sections are a too much problem. And if this was only happening in the US and Bangladesh, you'd probably assume that there were different things driving it. But at its core, the fact that on almost every continent, C-sections are rapidly skyrocketing, it seems like there could be something in common that's driving it, and that's not likely to be medical malpractice or reimbursement. So this is a lot to take in at once in this graph. I usually try to build it up in pieces. Basically what it shows is on the y-axis you're seeing C-section rates, and on the x-axis you're seeing time. What it shows you is that in the early 1970s, the C-section rate in the United States was 5%. And then what it shows you is that basically every 5 years, it first doubles, then it triples, then it quadruples, and then it quintuples. That brings us to the 90s. Then what happened is the end of the millennium was coming up, and in the year 2000, we set a bunch of population health goals. Actually, we said by the year 2000, there are a bunch of ways that we want to try to make the country healthier. We called it Healthy People 2000. And one of the ways was to bring down our C-section rate to 15%. And so at the beginning of the 90s, we did that. We started to drop the C-section rate down, and we were right on target. Then in the mid-90s, we changed our mind and rapidly reversed course. And then just in the last decade alone, C-section rates went up by another 50%. So overall, we've seen a 500% increase in the use of the surgery over the last generation or two of moms. And there are, a number of things that people use to try to explain this as part of the conventional wisdom, and they essentially don't bear out. So electronic fetal monitoring is a technology that was introduced in the early 1970s that was meant to make babies safer, but the only thing it does reliably is increase C-section rates. The thing is, it fully saturates the market within 3 years, and so the way that we use it in the 70s, 80s, 90s, 2000s, and 2010s hasn't really changed. And so you can't really explain the entire trend line just based on that. Some people also point out that most families are larger than one, and if you have the first C-section, you might get the next one. That's what a trial of labor after a cesarean is. And so we promoted this practice of letting women have normal deliveries after having an initial C-section for a little while, and then we stopped emphasizing it. So some people say that that could be part of it. The thing is, though, this black line is the C-section rate just in first-time moms at the exact same period. And what's spooky is they look like railroad tracks. They go down at the same time, they go up at the same time. And that means that there's something else modulating C-section rates. Some people say that moms are older than they used to be in the 70s, that there's more obesity and hypertension, there's more IVF and twins and octomoms, I guess. But it turns out that the demographic shifts in our country also explain very little of this, because C-section rates have gone up in 18-year-olds just as fast as they've gone up in 35-year-olds. And there are more 18-year-olds having babies still than 35-year-olds. The idea that patients are demanding this doesn't really bear out. It's less than 0.5% of patients that request C-sections. We see this trend independently of medical malpractice, of reimbursement, really everything else. So you can look at this over time. You can also freeze time and just look across geographies in this country. So this is a one-dimensional graph. Every dot on here represents a hospital in the United States from a nationally representative sample. What it shows is at the hospital level, C-section rates vary between 7 and 70%. That means there's 10-fold variation in C-section rates by hospital. It is the only thing I'm aware of in all of healthcare services research where when you risk adjust, you account for the fact that some hospitals see sicker patients than others. You actually see more variation, not less. If you only look at low-risk women at the hospitals in the United States, you see 15-fold variation. And what that means is that in 2017, a woman's biggest risk factor for the most common major surgery performed is not her medical risks or personal preferences, but to literally which door she walks through. That, of course, begs a couple of questions. And so today I want to try and take on a little bit of the first two. First is why? How can it be that within one zip code, going to one part of town versus the other can increase your chance of having a C-section by 500%? And then what can we do about it? How can we help patients navigate these options better? Consumer Reports about a year and a half, I guess it was exactly a year ago almost, decided to publish C-section rates at the majority of the hospitals in this country. And they found that in certain parts of the country, particularly Miami, Southern California, but really everywhere, including Kentucky and Boston, where I am now, two hospitals very close together can have wildly different C-section rates. So to try to understand this and what we could do about it, one of the things that we did early on is we surveyed women to try to understand how they think about quality measures in childbirth and C-section rates in particular. And we published this in the journal Birth about a month ago, where we surveyed about 7,000 women from a nationally representative sample. And we found that, probably unsurprisingly, most people don't pick hospitals, even though we measure healthcare quality at the hospital level. Women don't pick hospitals, they pick a OB or a midwife. And more than 2/3 expect that the OB or midwife that they see in the office will be the one that delivers their baby. We'll tell you most of those people will be disappointed. That's what a lot of women come in believing. Interestingly, about 3/4 of women understand that quality of care varies tremendously across hospitals, but very few value the existing measures that we work so hard to collect. And we showed them all the things that regulators and payers and accreditors and other people try and measure at the hospital level. And the gold bars show the number of people who either don't think that it's important or don't know if these things are important. What we found is that it's confusing because a lot of people said that they understand that healthcare quality varies tremendously from place to place. But when we dug into it, we found that hospital level measurement seems like an abstraction to most people. It's not clear to them how a hospital level C-section rate applies to them personally, that it could potentially affect their chances personally of having a C-section. And so the survey reflected that. Most don't believe that their choice of hospital will impact their chances of getting cesarean. In fact, because our survey methodology was such that it made it very easy to ask thousands of women's questions and get immediate responses, we had a little bit of fun with it, and we set up a bunch of thought experiments. Like, would you be willing to drive 20 miles more to go to a place at a 20 percentage point lower cesarean rate? And about half wouldn't. So this is not an advertisement, I promise. This is essentially a testament to the information economy, which probably is the most disruptive force, not only in healthcare, but really in the world right now. Ovia is one of the fastest growing startups in Boston, and what they do is they help people track their fertility. Interestingly, they get minimal venture investment. Most of their capital comes directly from clients, and their two biggest clients are GE and Blue Cross, one of the biggest employers in Massachusetts, or biggest employers in Boston, and one of the biggest commercial health insurance companies in Boston. Now, why would a payer and a purchaser of healthcare care so much about a fertility tracker? Well, it turns out that 25% of hospitalizations are childbirth related. C-sections are the most common surgery. There's tremendous variation. They're paying for that. It also turns out that reproductive age women are the target demographic for literally everything that you want to sell. And so in this app, people track their fertility, but they also put in a lot of demographic information. You know a ton about them. There's a GPS on their phone, so you know where they are. And you know exactly where in their fertility, pregnancy, or parenting journey they are, and so you can target messages to them accordingly. And if that sounds Big Brother-ish, it is. It could be used for good or for evil. And so we basically took the stance that this is an inevitability about how the world works these days. If you buy 2 things on Amazon, it will very quickly suggest a third to you, and it's usually right. And so companies like this are already using these kinds of technologies. And so we tried to see if we could go on the back end and figure out how to leverage it to help people make choices that lead to better outcomes for them. So we had a phase of this where we went on this app, which has hundreds of thousands of users across the United States, and we asked them a bunch of these questions to try to understand how they already think about differences among hospitals. We then did something called A/B testing. So those of you who ever read the news online, whether it's Fox or CNN or New York Times, if you go to a news article and you click on the headline, and then you go back a couple minutes later, you might notice that it's relatively common for the headline to change. That's A/B testing. What they're doing is they're putting out 2 headlines at once, and then they're figuring out which one gets the most traffic, and then they sunset the one that doesn't work as well, and they amplify the one that does. So we did the same thing to try and test different ways of messaging women, different headlines, different colors, different images, different core messages. These are some of the things that we tested. And then once we felt like we had a well-optimized message, what we figured out is that we could send women these optimized messages at a time while they're tracking their fertility and have not yet picked a doctor or a hospital to go to. Because they have a GPS on their phone, we could figure out what the 5 closest hospitals to them are and show them the C-section rates of those places. So this is what we're doing. And within this app, we've embedded a randomized controlled trial that has enrolled 20,000 women. And we're trying to figure out whether or not giving women targeted information in this way is more likely to get them to pick better hospitals. And this is sort of what it looks like in the app. But essentially, the trick that we figured out is that we need to be better at communicating what makes hospital A different from hospital B. And along the way, one of the things that I realized is that, and I'll be very curious to hear actually what Rena has to say about the star rating system, because it very much resembles Yelp. We're used to picking restaurants based on Yelp. And generally speaking, you don't pick a restaurant based on the waiter that you like. People understand that you can have the best waiter, the best chef, the best ingredients, the best menu, and still have a terrible meal and terrible service. There's something about the complexity of those environments and the way they're managed as a whole that has a big impact on your experience and your outcome. It's really no different from hospitals, but in the healthcare industry, we haven't yet done a good job of making that case. Coming close to time, I want to point out to you quickly that one way of understanding granular detail, what makes one hospital different from the next, is to literally just peel the roof off and look inside. This is what the modern labor and delivery unit looks like. And so the woman who's sitting there is a nurse who's in charge of the unit, who has one of the hardest jobs in all of healthcare delivery, because she has no idea when her customers are going to show up. If there's a full moon, the labor floor will be busy. That's pretty much all they know. They don't know how long people are going to be in labor, and they don't know which one of the patients is going to get sick enough for her to need to deploy resources or get an operating room ready or call the blood bank or whatever the case might be. So what you're seeing is she has 2 computer screens in front of her that are helping her with her nurse assignments, try to figure out which nurses go to which patients. She's got 4 other computer screens that help with her bed management, try to figure out which patients should go to which beds. There are 8 more screens on that back wall that have the heart rates of all of the fetuses inside of their mom's bellies that she's meant to be surveilling. And then my favorite part is that there's a dry erase marker board on that other back wall with 15 columns and 30 rows where she manually reproduces all that information because she doesn't like the way it's displayed on the computer. And basically what you've got is a person who's working as an air traffic controller. Without an air traffic controller's tools or support, you'd never go into an air traffic control tower anywhere and see only one person. But that's exactly what you'd see on the modern labor and delivery unit. And with all of that complexity, you can imagine that people's ability to manage that complexity is very different from place to place. And we've been able to show that people's ability to manage that complexity can very easily predict not only C-section rates, but all kinds of outcomes that we care about. Particularly given that the choice to do a C-section that's not scheduled, like many choices in healthcare delivery, is discretionary because in many cases, basically you're choosing between a high resistance pathway and a low resistance pathway. You can either just do the C-section and be done with it in 30 minutes, or you can continue to tolerate all the uncertainty and workload that comes with patiently waiting for somebody to labor. So my team in Boston now is working on trying to use all of these insights to try and sell a package of solutions to American hospitals across the country, taking an approach that's similar to drug development, I guess. If you were to try to go after a $5 billion market at a pharmaceutical company, you would invest in several years of R&D. So we are doing something very similar where we're spending a full year designing a prototype. We're going to spend a few more years doing the equivalent of a phase 1 clinical trial in a limited number of settings. You pick essentially the sickest and most motivated patients. We're doing something similar with hospitals. And then from there, you try to scale it up. To do this, one of the things that we realized along the way is that what we're dealing with are not failures of knowledge, but failures of execution. There's 2 sources of human fallibility: ignorance, which is not knowing the answer, and ineptitude, which is knowing the answer but not acting on it. And a lot of the clinical guidance assumes that what's going on is knowledge failures. So they present you with evidence, and they tell you something about the strength of the evidence, how much to believe it. What they fail to do is give you a sense of the impact or the feasibility. They often try to boil the ocean and give you a laundry list of things that you can do. What they don't do is give you a bet on what the simplest, highest yield actions that you can take are. And so that's the approach that we're trying to take. I'll end by saying that I think in the maternal health space, compared to other domains of healthcare, like cancer, for instance, well, it's true in all areas of healthcare that very little will change unless patients demand it. So figuring out how to engage and activate patients is critical. But in the maternal health space, patients have not yet been organized in a way that resembles like cancer, where you can have a meeting on the Hill and push a button and you have patients that'll show up, often professional patients with well-targeted messages. And maternal health isn't like that. I think it could be because women's issues get bundled together and child health and reproductive health crowd out maternal health. But in an effort to change that, we, on Mother's Day, have gotten a national park permit to use the Jefferson Memorial and try to build a large tent coalition of organizations, which include all of our professional organizations in maternal health, from the American Congress of Obstetrics and Gynecology to Lamaze International and March of Dimes and the National Partnership for Women and Families, and try to bring everybody together to advocate for increased investment in maternal health. So that's my advertisement. And that's my son, Luca, who will be there as well. So that's what I came here to say, and I'd be happy to take any questions.